Hi everyone, this is Amy Robillard. I'm doing my clinical with Garrity Family Medicine this summer, so working with an MD, and I'm going to tell you today about LL. His chief complaint is, I feel really dizzy. He's a 25-year-old African-American male who presents with persistent dizziness for the past 2 hours that he says just came out of nowhere. He had just finished his typical morning workout and was sitting, sipping a protein drink when he suddenly started to feel like the room was spinning. He says sudden movement does worsen the vertigo, but denies any specific head movement as precipitating the symptoms. He does feel somewhat off balance. He complains of some nausea, but no vomiting. He's got a mild headache above both eyes, but no photophobia or phonophobia. He does report mild left ear fullness times 1 day, but no tinnitus or hearing loss. He denies any vision changes, weakness, paralysis, numbness, lightheadedness, loss of consciousness, or neck pain. He says he hasn't had any recent neck or head trauma, though estimates a history of about 5 or 6 lifetime concussions. He doesn't have a history of migraines. He hasn't had a recent URI or been around any sick contacts. He does admit to driving himself to clinic, but says all he wants to do is close his eyes and lay still. Contributing past medical history, he has seasonal allergic rhinitis, but doesn't report any residual deficits from his multiple head injuries. Surgical history is non-contributory to this complaint. He takes no prescription medicines, occasional use of OTC NSAIDs, and specifically denies recent antibiotic use. Family history is significant for a father with hypertension and hyperlipidemia, but denies any family history of stroke or known atherosclerotic disease. He's a single guy, works as a professional athlete in a contact sport, does not use alcohol or tobacco. Review of systems, constitutional states he was feeling well up until this morning. The review of systems was mostly covered in the HPI. There are no additional skin, cardiac, pulmonary, GI, or MSK complaints. Neurologically, he denies feeling faint or feeling like he's going to pass out. He doesn't have any trouble walking, but feels a little bit off balance and says concentrating is difficult from the dizziness. On exam, he was visibly uncomfortable, holding his head low in his hands as eye contact was poor, saying he preferred to keep his eyes closed as this helped with the perception of the room spinning. His vitals were normal, including normal orthostats, nothing abnormal on the HENT exam. His hearing was intact. He had no spontaneous nystagmus. And I obviously focused on a thorough neuro exam, and there were no abnormalities found. So he's an assessment. He's LL's an otherwise healthy African-American male presenting as visibly uncomfortable with report of acute onset of severe vertigo, nausea, and subjective instability. The physical exam was completely normal. We decided that the likely cause of the vertigo was vestibular neuritis, and this is where the cochlear nerve is affected, and the precise cause of the swelling is not well understood, but some have suggested that it's that it's a viral cause. We ruled out a vascular event in the central nervous system as there were no focal neurologic symptoms. He had no prominent risk factors for stroke, and his blood pressure was normal. Other diagnoses we considered were migraine, benign paroxysmal positional vertigo, or BPPV, and Meniere disease. No further diagnostics are indicated for vestibular neuritis. We did start him on a prednisone taper for 10 days, starting at 60 milligrams for 5 days and tapering from there. We recommended that he take meclizine. Adjust the camera here. We recommend a meclizine 25 milligrams TID as needed for severe vertigo, and Tylenol for his headaches. Patient education, he was reassured that most patients with acute vertigo recover spontaneously over a period of 3 weeks, and severe symptoms usually last only a day or two. We asked him to follow up in 2 days, and the plan was if there was no improvement in 2 days that we'd consider neuroimaging and possibly PT for vestibular rehab, which is known to speed up the recovery. We recommended that he avoid driving while the vertigo was present, and he made arrangements for getting a ride home from the office. So the principal differential diagnostic concern in a patient who presents with acute vertigo is a vascular event in the central nervous system. The literature said that doing a head thrust test is usually negative in stroke and usually positive in vestibular neuritis. I didn't do this test when I assessed LL, but I kept seeing it in the literature about vertigo, so I was curious about it. So I chose to review an article about head thrust, which is also known as the horizontal head impulse test, or HHIT. So with this test at rest, the patient is asked to fixate on a distant target. And then the patient's head is rotated rapidly by the examiner to one side, like this. So in a normal response, the eyes remain fixed on the target, but in an abnormal response, the eyes are dragged off the target that require a corrective action or a corrective shift in the gaze once the head stops moving. So this would be a positive H hit. And then the test is repeated on the other side. So the article I reviewed had an objective as assessing whether or not this H-HIT test had diagnostic accuracy in distinguishing between peripheral from central causes of acute vestibular syndrome. So they looked at 43 patients with vertigo over a period of 6 years, and the results showed that 100% of patients with vestibular neuritis had a positive or an abnormal H-HIT test, and 91% of patients with stroke had a negative or a normal H-HIT test. So the conclusion here, I think, is that patients with stroke can also have an abnormal H-HIT test, so the sign can't be solely relied upon to rule out stroke. Nonetheless, it's a useful bedside test when acute vestibular neuritis is suspected, and the results also suggest that if the H-HIT is normal, then you can rule out vestibular neuritis. Thanks so much.